Tonight's program on dispelling myths about smoking, mental health, and substance use disorders will be presented by Rosemary Bak Lowery. Rosie is a certified health education specialist who has been working in the health, fitness, and wellness industry for the past decade. Along with her passion for health promotion, she brings in-depth personal experience and academic knowledge of mental health issues, substance use disorders, and recovery. In 2015, she was proud to publish her first academic article in the Health Education Monograph, Using Technology to Help Individuals with Co-occurring Disorders, a dialectical behavior therapy intervention informed by the trans-theoretical model, which proposed a novel mode to address drug addiction and symptoms of mental illness in a personalized, confidential manner. She completed her Master of Science degree in Community Health Education at Eastern Michigan University. She's also the brand new mom of an adorable little guy named Tommy, so we especially appreciate her willingness to be here tonight and talk with us. Please join me in welcoming Rosie.
Hi everyone, thanks for coming tonight. I think that to start, it's always good to just say that you're nervous, and then maybe you won't be as nervous. And bear with me because mom brain is a real thing. But my baby gave me some good luck drool just before I left, so I think I'll be good. This is something that I'm really passionate about, and I based my master's research on this, which I conducted while I was in the throes of sleepy first trimester without ADHD medication, but I swear to you that it's good research, and so now I'll be presenting to you also without the benefit of ADHD meds and with mom brain. Anyway, that's my disclaimer. So my intro here, I just want to give you my credentials. Why should you listen to me? I don't know. And some premises and assumptions going forward, mostly about like verbiage, terminology, and just an overview of what I want to go through today. I will say what this is not off the bat. So this is not another how to quit smoking. I will give some resources if that's something that you might be interested in for yourself or for others. There are some resources out there, but I think that that's been done a lot. So I'm just going to keep that part really general. It's also definitely not a lecture about all the reasons why smoking is bad for you, because I think we already know that. So, so my credentials, you know, alphabet soup, different certifications, whatever, not to mention diagnoses. Let's just say the most important thing is what I will call my street cred. That's my little guy on the street, which is basically to say that I've lived this. I am an ex-smoker myself. I smoked on and off for 17 years, and I quit many times. Which of course also means that I started up many times, but the last time I did was 8 years ago this month. So I feel like that stuck. So I guess my one and only PSA for today would be just don't quit quitting. Okay. So premises and assumptions. So just some terms, because I think that language is really important. So I just kind of want to get us all on the same page. So, you know, the audience at the Dawn Farm presentations are, you know, a kind of a diverse mix of people. We have family members of people in recovery. We have people in recovery. We have clinicians, staff. These kind of terms I'm going to use interchangeably. So mental health, substance use disorder, MH/SUD. It's really a mouthful. Also kind of known as like the behavioral health population or consumers, clients. I'm just going to prefer to use the term people in recovery. Just to lump that together. And I know that for maybe some people that are in recovery, that have or have not been diagnosed with substance use disorder, it might be a stretch to think of it as a mental illness, but for the purposes of most research, it is considered a mental illness, and I would just, you know, think about the often cited insanity of addiction, and you can, see how it would be considered a mental, not to mention physical and everything else, spiritual illness, right? Okay, so just people in recovery is just probably what I will say for the most part. But I might also say mental illness in that generally includes substance use disorder. So then also clinicians or staff. I do have some content that's tailored toward people that are working in the field, maybe they're therapists or peer recovery specialists or what have you, but that content is also relevant to people, consumers, community members. So just ask for you to keep an open mind. You're welcome to ask any questions. If you have any burning questions throughout, just raise your hand or shout it out, I don't care. And then I will have a couple little 1 or 2 breaks for discussion throughout, and then we'll have time at the end for more Q&A and discussions. Okay, so basically what I'm going to be going through is just kind of a brief overview of the public health problem of smoking in this population. Common misperceptions and the culture of smoking, that's kind of the meat of what I want to talk about today and get people thinking about. There is a solution, and that gets into a brief intervention that clinicians can use to help people to quit smoking, and some resources for people. Okay, so the first part, I feel really glued to my podium. You said I'm going to look like a Smurf if I stand in front. Do I look like a Smurf now? Okay, well, anyway, so the public health problem of smoking, rates of mental illness, just kind of an overview. So anybody, the lifetime diagnosis, so if anybody has ever had any mental health diagnosis, that's 1/3 of adults in the United States. Current people in the past month, that's 22% of us. And this population smokes 44% of all the cigarettes. According to the CDC, 36.1% of adults with any mental illness smoke, and that's compared to 21.4% of adults with no mental illness. Now, this statistic did not include people with substance use disorder. So when you actually look at, to include that, the rates are even higher. People that are currently abusing or dependent on alcohol, 56% of them currently smoke, and 67.5% have ever smoked. People with current drug abuse or dependence, 67.9% currently smoke, and 87.5% have ever smoked. So it's a heck of a lot more than the general population. Here's the one that really I want you to remember. The average life expectancy for people with mental health and or substance use disorder is 25 years less than somebody without one of those diagnoses. And I have references on the handout, but it's not all of the references put together. So just in case you're, not convinced, I'm happy to share the references with anyone afterwards. But the major causes of death for this population, the top 3 are cardiovascular disease, respiratory or lung disease, and diabetes. And smoking actually will cause or contribute to all of those. So it's basically been said that there isn't another field in public health that has as much potential for preventing death or disability. It's completely preventable. So that's basically why I chose to, that's why I'm so passionate about it, because it really is a major public health problem that affects a lot of us. Okay, so why is this still happening? We've seen smoking rates go down in the general population over the years, but it hasn't gone down as much in people in recovery. And what I found is that there's a lot of really common myths and misperceptions that are perpetuated by people in the industry, in the recovery world, in the mental health world, behavioral health world. So it basically comes down to, what did I have, about 7 or so different themes. So this is what I'm going to go over. So on the left, that's the myth, and then these are the facts on the right. So people in recovery don't want to quit. You know, a lot of people that are on the treatment side are like, yeah, I'm not even going to help people because they don't want to quit. Well, the research shows that as much as anyone else, we do want to quit. 70% of people in recovery want to quit. 40% are in that contemplation stage. They're kind of thinking about it, you know, as opposed to pre-contemplation. So I'm talking about the stages of change here that a lot of us are familiar with. Pre-contemplation is like, yeah, it's not a problem, I don't care. You know, a lot of people are, on some level, they're thinking about it. About a quarter are actually in the preparation stage, where they're like, yeah, you know, I'd like to kind of make a plan to quit. You know, I just got to get my stuff together. You know, maybe in the next 30 days, I will try to quit. Another myth is that people in recovery, people with mental health and or substance use disorder can't quit smoking. That's a really big one. Okay, so the quit rates are substantial if slightly lower. So what does that mean, slightly lower? It's barely even statistically significant. It's like, forget about it. It's basically the same. The quit rates are almost equal for those who are abstinent, especially compared to the general population. So it's, with what the research shows is that there's not a huge difference in people's ability to quit. Okay, but I need to quit for this first. They need to quit this first. This is a huge one, right? I need to get sober first. I need to quit alcohol. I need to kick heroin, you know, whatever it is. Quitting smoking doesn't interfere with abstinence. And this is a little bit more recent research that shows that non-smokers or quitters are actually 25% more likely to stay clean, sober. So that means either if they didn't smoke to begin with, or if they quit while they're quitting everything else, they're actually 25% more likely to stay clean, sober, clean and sober, whatever you want to call it. And actually smoking is associated with a greater risk of relapse. Okay, so it's needed to manage symptoms. And that's not just for you know, people with mental health diagnosis. If you buy the idea that addiction is a type of mental health diagnosis, mental health actually improves after quitting smoking. Smoking is a risk factor for suicide. We don't know why, but it actually is associated with increased rates of suicide. And smoking increases the need for antipsychotic medication. So for those that actually do have, you know, a more traditional mental illness, maybe taking an antipsychotic like Depakote or Respirodol or what have you, it somehow makes the body metabolize the prescription faster, and so actually the person will need more of that medication to have the same effect. And then of course that introduces the risk of more side effects, etc. Okay, people in recovery have bigger problems than smoking. That's a big one too. You know, I don't have time to do this with my clients because they have other bigger problems, but smoking is the #1 killer in the behavioral health population. As I said before, it's related to the top 3 causes of death: cardiovascular disease, lung disease, diabetes, and smoking is a top 3 predictor of future suicidal acts. Don't really know why, but probably, well, maybe because your mental health improves after you quit. It's not my job, so here's a staff member saying that. And so I'm appealing to people that work in the industry and say, you have the ideal skill set. You might be your client's primary care provider. And even if you're not, you're going to be seeing them a lot more often than their primary care physician. A greater frequency of contact means better success in quitting, and it's the right thing to do. Okay, and the last myth is I don't have the time. The Department of Health and Human Services recommends a brief intervention at all visits. It can take just 3 to 5 minutes, and I am going to review the skills of the brief intervention today. So, lest everybody fall asleep, I want to get you guys talking a little bit. So, what do you think about that? How many of those myths did you believe to be true? Can you relate to any of those items? Were any of those excuses that you use to keep smoking or to keep from helping or encouraging others to quit? Do you still believe the hype despite what the research shows? So you quit smoking and drinking at the same time because the doctors told you to. And how did it work out for you? 40 years later, clean of alcohol and cigarettes. Right on. That deserves a hand. So it helps to understand the why and the what ifs and what's going to happen. So you said you're not skeptical at all because you quit smoking 3 days after you quit drinking, and yoga was really helpful for you, and you were you use the phrases "don't quit quitting" and "lead by example," something to that effect. 4 years ago, right on. I want to hear from the naysayers. Somebody's got to be like sitting back there going, this is all not true at all. Might be true for these people, but it's not true for me. So he was asking, smoking is a top 3 predictor of future suicidal acts, and how. And I don't know how. It's just a statistical correlation that's been found through research. And I'm not a statistician, and I don't know that anybody actually knows how, but it is it's correlated. I can share with you the articles, though. If you, I'm going to share my my email addresses on here, and I have all the references that were used to put this together. If you want to read more about it. Right. So it's confusing because people in recovery say, don't make any major changes in the first year, and yet here I am saying you should quit smoking while you're quitting drugs at the same time, and which one should you do? I guess, and I've definitely heard that too. I think that a lot of the time people are talking about getting into a new relationship or moving across the country. I think it could be argued that quitting drugs is a huge change, and cigarettes are another one of the drugs. You know, it's like I would challenge the common point of view that cigarettes are separate. To me, just me personally, that would be like saying, well, I'm going to quit hard drugs, but alcohol's okay. Like, we all know that that's not okay. Maybe if you put it in the category of drugs, there's a guy, you can look him up on YouTube. It's Kevin McCauley, and he has some videos about his addiction and disease and things like that. And a lot of the research suggests that when we continue with other addictions, it kind of keeps the circuitry alive in your brain that, and even things like, you know, swilling Red Bull all day long, he says that even that can like kind of keep that circuitry alive. So maybe that's why people have greater success in being abstinent when they quit cigarettes too. That it's another, you know, put it in the category, that would be my suggestion, would be put it in the category of all those other drugs. You know, I'm not just gonna quit cocaine and not quit heroin, right? I'm not gonna quit alcohol and not quit pot. You know, so nicotine, I'm going to put that in that same, cigarettes, I'm going to put that in that same category. That some of your like recovery coaches and stuff will say, yeah, don't quit smoking, you know, it'll help you manage stress. And honestly, okay, so my original, this presentation was originally given to a community mental health agency where they treat a lot of people in recovery from substance use disorder and or mental illness. And the whole reason that I chose them to target it is because that it is a part of the problem. It's a big part of the problem. That's what a lot of my research showed. And the next part is actually, that's a good lead-in, is kind of about the culture of smoking that really is perpetuated in the recovery community. You know, there are absolutely a lot of people that work in the recovery community that smoke and that don't, you know, that subscribe to all those myths, and you know, maybe they just don't know better. So my whole like mission here is to try to shed some light on it. You know, some of the stuff I believe too. I thought that maybe you do need to, you know, maybe it is needed for self-medication, but the research shows that it really does not help our mental health at all. I will say one thing, that nicotine withdrawal is a thing, right? It's even in the DSM-5, and it has symptoms that could emulate mental illness, like anxiety and fatigue and irritability, but it's a time-limited thing, and also that's why nicotine replacement therapy is suggested, and we'll talk about that later. There's not, you know, nicotine itself doesn't cause all of those issues, which is why a doctor will give you nicotine, right? They're not going to prescribe you cigarettes, but they will give you a patch or whatever. So, yeah, maybe you can be that light that says, hey, you know what, I know better. Ooh, that's deep. I haven't heard. So she's talking about Kevin McCauley. You said it's a hedonic set point, like your set point for your hedonism, your pleasure center, and it gets jacked up when you're smoking all the time, when you get used to the dopamine hits. Okay, so we get used to kind of being up here in the dopamine realm, and then after a while so we don't feel good when it's not being boosted, but right. And then also, you know, I feel like this is as good a time as any to mention that there is a 12-step program for nicotine, and Nicotine Anonymous, and I think there's maybe 3 meetings in the whole state, and one of them is not terribly far from here. It's in Dearborn. I'm going to move on to, since that was a pretty good segue, the culture of smoking and staff's role, but also if you're not a staff person, think about your role also, because if you're a consumer of recovery services, then you're interacting with staff. So I'm going to play 2 short videos, and I just want you to think about some of these things while they're playing. So just some food for thought. What thoughts and feelings about smoking and quitting smoking are provoked by these videos? Are you a recovering smoker? Do you feel it's important for people in recovery to quit smoking, or do they have bigger problems to worry about? Do you think it is or should be a part of the role of a behavioral health or addiction professional to help their clients to quit smoking? Ask yourself, can I be a part of the solution? Okay. So, interestingly, you guys are probably familiar with thetruth.com. Maybe? Anyone familiar with The Truth? They have those kind of edgy PSAs and things like that. So they put out a report about mental health and smoking, and the full report was about 4.5 minutes, and it went into a lot more detail, and it just disappeared from the internet, which I think is really strange. And I'm not going to say it's a conspiracy, but I don't know. I think they might have mentioned some tobacco companies by name because they had a history of actually giving free cigarettes to psychiatric wards. But this is the 30-second report, so this is kind of like the really quick synopsis of that.
Do you think that tobacco companies targeted people with mental health issues?
They go after people with mental illness, people with depression, people with anxiety.
Big Tobacco went as far as giving free cigarettes to psychiatric facilities.
It's despicable.
The consequences of this targeting are horrific. People with mental health or substance abuse issues account for 40% of the cigarettes smoked in the United States.
It's sick. It's twisted.
Know the truth, spread the truth, finish it.
My name is Dylan, and I'm a smoker. I want to quit, of course. Who doesn't? But things are a little harder for me. I'm living with mental illness. One day someone will mention how bad it is for me to smoke, but then someone else will say, well, everyone dies of something. Makes sense, I guess. I'll visit the doctor and she'll be so concerned with my illness that she won't even worry about the smoking. After a while, I meet someone who becomes my best friend, Karen. She has schizophrenia and it gives her a lot of trouble. She has to go to hospital all the time. But it makes her feel better when we sit outside having a smoke, talking about things. The next time I go to see her in hospital, I'm sitting opposite her when the doctor tells her that she has lung cancer, that she's going to die. Before she passes away, she looks at me and says, everyone dies of something. There's those words again. So after what happened to Karen, I decide to quit. I say, starting Monday, I'm going to stop, for real this time. I try really hard, but it doesn't seem to stick. It's just so much easier when I smoke cigarettes. It's the 6th of October, Karen's birthday, and I light a candle for her. As it's burning, I light a cigarette from the flame, and then it hits me. I realize what I've done. I put out the cigarette right there, I don't even finish it. I throw out the packet and make a promise. I will quit smoking. Like every other time, it's so hard, but this time it sticks. I'll try things I haven't done before to keep my mind off cigarettes. And it works. I actually stop smoking. Pretty soon I can stand outside when everyone smokes, and I don't want to have one. I'm getting really good at painting. I have to restring my guitar every month now I'm playing it so much. It feels great to do these things. It's hard trying to do it alone, which is why it's great that I've found MIFSA. It's so nice to know there are people just like me, people going through similar things, and we help each other. And I'm part of something. And every day I'm getting healthier. Every once in a while, I hear someone say, everyone dies of something. They're right. Everyone does die of something. For me, I don't want that something to be cigarettes. If I can do it, so can you. Nothing's impossible. Contact MIFSA today to find out how you can help yourself and support others to quit smoking.
They were nice enough to let me use the video, even though obviously they're in Australia, so I'm not exactly promoting their program, but just the idea of having a community, or I don't know. What do you think? I just want to have a little break again. What's your role? Ask yourself, can you be part of the solution? Do you think it is? Any clinicians out there, do you think it's your job, people in recovery? Do you think that it's a job of a recovery coach or a therapist or anything like that to help you quit. Any other thoughts that come up? So this person said that, given that it's an addiction, nobody else can tell me as a smoker to quit. If I, just like any other drug, if someone was trying to tell me to quit heroin, I couldn't do it until I was ready. And I agree with that wholeheartedly. From a staff perspective, that's where things like motivational interviewing come in, because it really is not at all about telling somebody what to do, which is also why I didn't want to come up here. I really hope that I don't come across as lecturing. I do want people to be aware of, what the problem is and what the facts are. But everybody knows that smoking will kill them. That just like any other drug addiction, I've heard somebody say at an open talk one time, like, death doesn't scare an addict. That's not why they quit most of the time. Yeah, right. So that highlights the difference between telling someone what to do and encouraging and supporting them to make a healthy choice. So I'm here for you if you're ready to get help. Talking about the decline in smoking and the culture of smoking in the recovery community, where it used to be you'd walk into a meeting and it was just like a big fog and everyone was smoking, and then it was just a smoking table, and now it's just people smoking outside. I will say, I don't think that I meant to convey that everybody in recovery smokes. There are very high numbers of people, but also that people who are sober tend to smoke less than people who are still out using. And that's a good trend that it has trended downward in the general population and in people in recovery, but and I should have made a graph for it, I'm sorry. But if you were to compare the rates of the general population, the smoking has gone down like this, right? Whereas in people in recovery, it's more like this. So that's the biggest problem here, is that whatever's going on in the public health sphere and in the culture is making people quit, but it's not so much for people in recovery. And why is that? And these are some of the reasons. So I would just suggest that you tell yourself, yes, I can be a part of the solution. Just a suggestion. Okay, so any other comments or question before I get into the solution? The solution. I'm just going to say, there is a solution, okay? Best practices, just what the research shows, the evidence-based smoking cessation intervention best practices. Counseling, referral to telephone quit lines, nicotine replacement therapy, and pharmacotherapy or medications. So that, like all of those together, that's basically what the best practices are. So if I were a care provider, that would be kind of like my recipe for if somebody said, I'm ready to quit, this would be what I would do for them. Just a word about that. So nicotine replacement therapy includes the patch, the gum, lozenges. Nicotine inhaler does not include vaping. That's a whole nother thing, and that's not nicotine replacement therapy. I just want to put that out there. And then also people with mental illness and or substance use disorder typically benefit from a longer treatment of the pharmacotherapy. So Chantix or Wellbutrin basically are the two things. And let's say for somebody without a mental health diagnosis, let's say they would take Chantix for 3 months, that the research shows that people in recovery might need like 6 months of that to effectively quit and stay quit. And I can say from my personal experience, the last 2 times I quit, but like I said, the last time was it's been 8 years, so I feel like I got it this time. Knock on wood, or whatever that is. Anyway, it was Chantix, and I did the first time I found, I didn't take it for quite long enough, and I started up again. The next time I took it for longer, like longer than I thought I needed it, and that did it for me. And I also had nicotine replacement therapy, and yeah, so that I can say for myself, my own experience, that worked for me. So you're saying Wellbutrin is used as an antidepressant, as well as for quitting smoking. If you had an ambivalent smoker with depression, would that help? So I don't have research about that, but my personal impression would be that if that ambivalent person is not ready to quit, then no pill is going to magically make them want to quit. Although for me, Chantix had the effect of making me hate smoking. It was, I already hated it, but I liked it, and then the liking part went away because it covers up the receptors that make it feel good. Wellbutrin never had that effect for me, but that's just me. I've known other people that have taken it for quitting. Yeah. Okay, so was that an effective way for you to quit? Awesome. So you have somebody that was depressed and quit with Wellbutrin because it didn't feel good anymore, and then he realized that his mouth just tasted like an ashtray. Anyway, so it's a little bit more targeted toward the staff people here, but so recommended strategies here include motivational interviewing. So that's, when somebody's ambivalent, when somebody, we don't want to tell somebody, we don't want to lecture somebody. That's where that motivational interviewing is a wonderful skill for helping people help themselves to quit smoking. TTM, tailored intervention. So the trans-theoretical model, stages of change, talked about it a little bit earlier. Pre-contemplation, contemplation, preparation, action, maintenance, maybe termination, maybe relapse. So tailoring the interventions to what stage of change somebody is in is huge. Cognitive behavioral therapy and support groups. And so basically, because those are the recommended strategies and tools to help people quit, behavioral health providers are really in a key position to help because they have those skills. You guys have those skills. More points of contact is associated with greater success. So if somebody is in like a clinic setting and their psychiatrist and their therapist and their peer support specialist and their case manager maybe are all saying, it'd be good for you to quit, or I can help you quit. It's associated with greater success. Okay, so the brief intervention, that's the thing that's really recommended for clinicians. And this is my brief kind of didactic teaching portion of things. The 5 A's, so that's ask, advise, assess, assist, and arrange, or as a shorter alternative, 2 A's and R, ask, advise, and refer. So clinical people, staff pay extra attention to this, but community, people in recovery, consider this your look behind the scenes. Okay, so I have about 5 minutes worth of videos, so if you want to take a smoke break, just kidding. Just kidding. She's got jokes.
When we offer brief intervention, we increase the likelihood that a smoker will quit by around 30%. But what do we mean by brief intervention? Brief intervention, which we sometimes refer to as the 5 A's, can be defined as an intervention that takes 2 or 3 minutes to apply. We often believe that smokers don't want to quit, and the evidence suggests that maybe 7 out of every 10 smokers are interested in smoking cessation. And we often believe that when we approach smokers at the bedside that we will face hostility or anger. The reality is that we very rarely do, and one very easy way to disarm anybody who may in fact respond negatively to that questioning is to ask for permission to discuss smoking cessation. When we do so, we do our first A, we ask, we document status, and we move on to the second A, advise, and we advise that smoking cessation will be the single most effective thing that that individual could do to improve their health both now and in the future. We need to do this both empathically and non-judgmentally. The third A is to assess readiness. A very simple question along the lines of, are you interested in making a quit attempt within the next 30 days? If the answer is yes, we can reasonably say that that smoker is in the preparation stage of change. And we can move on to the fourth A, which is to assist. And we can assist in a variety of ways, but assisting is primarily by offering counseling, medication, or in fact both. Where it may not be appropriate to counsel at the bedside, we can very simply make a fax referral to Quit Now Services. Quit Now Services is a telephone quit line that is available free to all British Columbians. And the final A is to arrange, which may or may not be appropriate in an acute setting. Your involvement for the Hospital Smoking Cessation Pilot Programme is going to be crucial, and we thank you for your involvement. Thank you.
So I'm going to prescribe some antibiotics for you. I think the cough and phlegm is a lung infection. Okay. And within a few days of taking these antibiotics, you should feel considerably better. Now, I'm hoping that we can talk about smoking today. Is that something you'd be comfortable to talk about?
Okay, sure.
How many cigarettes are you smoking per day right now?
I've cut down, I think, because of just not feeling well, so probably about 15 to 20 cigarettes.
Right. And it's been many years.
Gosh, about 20 years, yeah, a long time.
And you understand that quitting smoking will be the most effective thing that you could do to improve your health right now, particularly in the context of these lung infections. I think this is the third one we've treated this year.
Yeah, it's just, I've tried in the past and I just get so cranky and angry and frustrated, and it makes it really hard to continue.
Right, so you found it tough. Is quitting smoking in the next 30 days something that is realistic for you?
Wow, I hadn't really thought about it, but I suppose I could give it a try.
And you mentioned being cranky and irritable. Those withdrawal symptoms are reasonably common, and there are ways in which we can help you to manage those withdrawal symptoms. Certainly the medications, of which we have a number of options, will minimize or eliminate the withdrawal symptoms. We have a number of nicotine replacement therapies, patch, gum, lozenge and inhaler. And we also have 2 prescription medications, varenicline and bupropion, all of which are effective and all of which will mitigate those withdrawal symptoms. And then we have a number of counseling options as well, so we can provide you with some one-to-one support within the clinic, or we can refer you to a smoking cessation group, and then you have the option of using the telephone quit line, Quit Now Services. So I can just simply do a fax referral to the Quit Now service, and they will contact you and set up a system of support to support you through a quit attempt.
I didn't know that they offered things like that, so yeah, I mean, I would definitely want some more support. That would be really helpful.
So we could certainly set up the quit line for you. Okay. What about medication? Does that interest you?
People say that the patch is really helpful, so that's something that I might be willing to consider.
Right. The patch is a good option. It's been around a long time. It's safe. It at least doubles the likelihood of you being quit at 6 months after your quit attempt, so I think it's a good option. So what about a quit date? Have you thought of a time that you would like to make a quit attempt?
I'm hoping to feel better soon and be back at work next week. So, if I'm occupied during the day, I think that would be a good time for me to start.
So you make a quit attempt next week? Great. So we'll arrange to see you again, maybe around that time, and follow up and see how you're getting on.
Okay, that sounds good. Thank you.
So obviously it's not always that simple and easy on both ends, you know, as far as that goes, but just, you know, for the sake of an example. So asking is basically just to identify and document tobacco use status at each client visit. So it was, you know, not anything accusatory, just simply asking, you know, are you smoking? How much are you smoking? Advising to quit in a, you know, a strong, personalized way, and very important to be non-judgmental. Assessing the person's willingness to make a quit attempt, and that's where motivational interviewing really can be helpful. Assisting as well, so providing interventions that are appropriate to the person's stage of change. If they're absolutely not ready, then maybe it's just saying, okay, well, I'm here when you're ready to discuss it. And arranging follow-up. So the shorter version of that, oh, I just realized I have a pointer. I forgot about that. Is just to ask. I'm going to use it just for this one thing. Ask. Advise. You know, nobody wants to hear somebody go on and on and on about how bad smoking is for them, but at the same time, I just want to reiterate that this is the evidence-based recommendation from the CDC and DHHS. Simply just having a caretaker, a care provider, that is, you know, whether it be a therapist or a doctor or a peer support specialist or what have you, asking and advising over time, it increases people's rates of quitting. So anyway, so the shortened version of this is just ask, advise, and then refer. So maybe depending on your role, this assess, assist, arrange is not really your role. So asking, advising, and then referring to someone else on the team that would then, you know, maybe a therapist that would then really talk and try to assess the person's willingness to quit and assist them and so on and so forth. Okay. Are there any questions about that before I move on to some resources? All right, so just quickly some resources for quitting, and all the slides are printed, so if you want to take these home, you will have that for you. Just a reminder of the best practices for evidence-based smoking cessation treatment, counseling, telephone quit lines, nicotine replacement therapy, and pharmacotherapy. All of the above is what a lot of people need. Okay, so consumer resources, 1-800-QUIT-NOW is that quit line that I keep talking about. BeTobaccoFree.gov, SmokeFree.gov, TheTruth.com. Those are all really good resources if you find yourself wanting to quit and needing some further help. I should mention that nicotine replacement therapy is free for certain insurances. I believe with Medicaid you can get free NRT. And if you call that 1-800-QUIT-NOW, they should be able to give more information about that. So just in case finances are a burden or a barrier to quitting, buying that first box of patches or gum or whatever. And then some resources for clinicians, and like I said, those are all on the slides, and we can email people the presentation also. You can just type in those long URLs. The California Smokers Helpline, this one has quit smoking stuff targeted toward people in the behavioral health profession. And the SAMHSA is a really good resource too, and the CDC. They're all good resources. That's why I put them there. Okay, general resources, American Cancer Society, American Heart Association, American Lung Association, and again, thetruth.com. Okay, so basically wrapping up my part of the presentation, the take-home message is that people in recovery can and do quit smoking. Being a non-smoker is associated with improved mental health and greater success in recovery. So if you remember nothing else from today, remember that quitting smoking or not smoking actually improves your state of mind and your sobriety. You are a key part of the solution, and there are quick and easy ways you can help and get help. So I'm going to make you guys write. Hopefully everybody has a pen and a piece of paper, or you could tap in something on your phone. I would love for you to write one takeaway from this presentation. Maybe an action item you're committed to, or even a question you're going to try to answer, or an attitude that you've changed thanks to today's presentation. We have plenty of time for any further discussion or questions or comments, and I really appreciate you all coming today. My contact info is on there in case you want any further resources. I have a full reference list that was just way too long to put on the on anything, because it's probably about 50 different articles or anything else. Yeah, so there weren't any references about exercise and quitting smoking, either as an aid or an incentive to quitting. That's because those references are just to back up the facts that are in that little handout. So there's certainly a heck of a lot more that can be said and learned about, and I agree that exercise is a great way to quit and to stay quit. For a future topic, like to talk about the industry behind tobacco. You know what? I bet you thetruth.com has something about that, because their whole thing is about like uncovering the dirty truth behind big tobacco and all that kind of stuff. And you know, the clip that I grabbed was their series about like mental health and substance abuse. But I bet you they would have something that might answer some of your questions or shed some light on that stuff. I unfortunately know nothing about that. One thing that I do know is that when they raise the price of cigarettes, people quit. When they raise the taxes, that's actually a public health approach to quitting, to getting people to quit in large numbers, is to raise the prices. And that does get a lot of people to quit. But go to thetruth.com and let me know what you find out. Okay, well, everybody likes to be let out early, so thanks you guys. Thank you for coming today.